This week on the Physio Foundations podcast, I'm talking to physiotherapist and PhD student McGregor Hall about his tips for helping people manage their pain in the clinic. Welcome back to the Physio Foundations podcast, where we talk about the knowledge and skills that provide the foundation of expert clinical practice. So I've got a live podcast recording. You might have noticed that I've been speaking to people all around the world over the last over 12 months of this podcast. And I've been recording a lot via video conferencing, but I'm sitting in my office here at Monash Uni Physiotherapy, and I'm talking face to face, having a nice coffee with Mac Hall. So Mac is a highly experienced physiotherapist. He's got a special interest in pain and pain management in the clinic, and he's doing his PhD with us here at Monash Physio. And since he's sitting right here, rather than me doing a long and extensive bio on Mac, I'm going to ask him to tell us a bit more. So Mac, welcome to Physio Foundations.
Hi, thanks for having me.
Great. So let's go through the bio. Tell us about your interests and background, and who are you? Who is Mac?
Well, I grew up in a place in the States called Maine, just outside of Boston. So I was a pretty lucky kid. I had a house on a lake. We spent my summers sailing and water skiing, and my winters playing ice hockey and skiing. But there were no parties and no girls in Maine. So I went to college in New York, where I studied sports medicine. Spent a few years in New York, and then I went down to South Carolina and then back to Boston, where I did a surgical placement before moving to Australia and taking up physio. That was about just over 20 years ago. And at first I really hated the chronic pain patients. They were really difficult. They didn't follow that normal pathoanatomical type of healing, and I just found them really frustrating. And then it was probably about 12, 13 years ago, I thought I might need to learn how to treat these patients and learn more about them. And I've actually really enjoyed it now and find it some of my most satisfying and favorite patients are the ones that have persistent pain or chronic pain.
That's interesting and very honest. So you found that frustrating, not only, so why was it so frustrating initially?
Well, especially, you go back 25 years when I first studied, and, chronic pain really wasn't on the radar. Pain science was not really much of a thing other than your typical, nociceptive C fiber type of pain. And that was it. And when you had patients that didn't heal, their tissues either didn't heal the way that you thought it would, or that it did heal and they still felt their pain, like I didn't know what to do with them because they just didn't match my understanding and my training and that normal, sequence of healing that 80% of people sort of go through.
So fast forward 20 years, and now that's your special interest in physiotherapy. How often is that the way that you've got something that you either felt unconfident with, or you didn't like, or you were frustrated by, and you thought, hang on, what is it about this that's I don't like? Or what is it about that? And you do that with people as well. And then that becomes your special interest area of expertise, and you're doing a PhD as well, which we can talk about in a minute in the topic. So
I think it happens more often than not, well, at least fair bit with a lot of things, physio and just in life in general. You start out thinking that you're going to go one way and you end up somewhere else. Never thought I'd be in Australia.
Yeah, that's amazing. Yeah, so you work in a local clinic nearby. You're working, doing some teaching, and you're doing your research in the form of a PhD here at Monash Physio. And I thought it would be a good chance to introduce you to everybody. And I know that you've got a really nice way of explaining some very complex concepts, particularly related to persistent pain in the clinic. And that's what I wanted to chat about. So let's start with a very big overview. What is pain?
Well, pain is the classic definition, I guess, of pain is just any uncomfortable experience. We typically thought of that as being associated with some sort of injury or tissue damage. It's now broadened a little bit more to include a lot more of an emotional component as well. Essentially, pain is what the person is experiencing now. We seem to just think, well, what is their pain? It's what they're feeling.
And I guess the related question then is, why do we experience pain?
Yeah, well, it's a few things. I think mostly it's to keep us safe, to protect us from threat and danger. And so pain is our body's way of letting our brain know that it's hurt itself and that it needs some protection, and to make you aware of that threat. And typically, what happens is you become aware of that injury and it hurts. And so you protect it, and you might see a physio or your doctor or something, take some medications, rest it, give it some time. And usually after a period of time, the tissue makes some repairs, and then the pain goes away and you get going again. And that happens pretty reliably with most people, about 70 to 90% of the time.
Mm. And a lot of the time people seek treatment because of pain. So it's this powerful motivator for changing behavior.
Yeah. Pain is an unpleasant experience, and we don't like to be uncomfortable. So we try to do things to better our own, comfort levels. And that means seeing professionals or other people, taking medications and whatever it might be to try and reduce pain.
So we see pain as a negative thing in many ways, but then we also recognize it as a positive thing if it's a part of a solution, right?
Yeah.
And that applies really nicely to an acute model. And I'm afraid of doing a false dichotomy here of acute and chronic or persistent pain. Mm. So before I go down that rabbit hole, what is persistent pain, and how's that different from acute pain, and what's going on there?
So I guess persistent pain, again, the technical definition is usually any pain that lasts longer than about 3 months is still classified as persistent or chronic pain. What makes it different from acute pain is probably we have this, this pathoanatomical model of tissue healing. So essentially when we hurt ourselves, some of our cells that make up our tissues die. And when they die, they release the chemicals inside of them. And those chemicals do two things. One is they activate the immune system to come and make some repairs. And two, they stimulate nerves to let the brain know that there's those chemicals there. Mm. And normally, white blood cells and macrophages and phagocytes and those sort of things come and they clean up the damaged cells and get rid of the debris.
Yeah.
And the cells that didn't get damaged, didn't get injured, that survived that traumatic event or that injury start replicating and making new cells and patching up the damaged area. And that usually takes anywhere between kind of 24, 48 hours up to 3 months in some tissue, depending on the type of tissue and the extent of damage. And then normally once all of that is cleaned up, the chemicals are gone and the pain essentially should go away. And that's what is, I guess, the typical acute type of pain. But in chronic pain, something goes wrong in that process, and even after the tissue repairs have been made or completed, the person still experiences pain for a myriad of reasons that we're still trying to figure out why.
Right. So that's really interesting. So tell us more about persistent pain. Why do some people have all of the contributing factors and all of the story that might lead them towards a pattern of persistent pain, and they don't get it? And some people end up with persistent pain. So what's going on as an overall picture?
Well, we know, like you said, there are some associated factors that seem to be associated with persistent pain. So essentially people that have high levels of stress, anxiety, depression, their mental status is maybe poor health, or they're just really wound up. That tends to be highly associated with persistent pain. However, it's not necessarily been proven to be causative, but it is highly associated with it. But yet you have people who have very high stress levels and anxiety and mental health issues who hurt themselves and they recover just fine. My work has looked at a lot of childhood trauma. So adults who as kids had difficult childhoods, that seems to wire their nervous system to be a bit more on high alert. Same with people who were victims of, attacks or car accidents, assault, those sort of things. They tend to be more likely to develop persistent pain, but not all of them. It's not exclusive. There's some genetic factors that seem to be pretty strongly associated with it, where essentially at the time of injury, when they do hurt themselves, those chemicals that we sort of mentioned at the start, they have a much higher bombardment or a bigger flood of those chemicals, which means that the pain will last longer and be stronger. But why do some people have all those, the so-called yellow flags that we think, oh, this is a high-risk patient, and then they never develop chronic pain? And that's a really good question. I think, and I'm purely speculating here, but I think that some of those people, it might be that they're their brains are essentially too full with other stuff that there's just no more room for one more thing. And so the pain doesn't get that foothold that maybe it would in someone else. I think some people have all those issues, but they actually are, actively trying to pursue better lifestyles and make their lives better. And so pain for them might become something that is just one more challenge that they're going to overcome. But we don't really know. It's a great question. Why don't some people develop chronic pain when some people who have almost the exact same profile in every sense of the word do?
So you got this analogy or this visual in your head of a line reaching full in your head where you've got the psychosocial, psychological, the biochemical, all these other factors combining. And then someone's reached a point where they've hit their limit. Interesting.
Yeah. And other people probably haven't gotten anywhere near that limit. And so the pain, there's plenty of room in their, I'm going to say their brain or in their person for that pain. And it won't necessarily become chronic because they're not, their cup isn't full enough yet. I think it's a fine balance.
It's a good way to lead into a question that I had, which was, if we're talking to our students, new grads, and anyone else listening to this who works with people with pain, and this is now a special interest of yours, you're doing your PhD in the area, and you're really good at helping people with pain, which is a really difficult thing to do. And you're also a really good educator, really good at talking about these concepts and summarizing them, which is why I wanted to talk to you here. What advice can you give students and new grads and people who are novices? I don't like the word novice, but they're less experienced than you in terms of tackling this really complex problem. So maybe in terms of assessments you would do, your approach overall, what are some of the interventions you do? It's a free blank canvas. What advice could you give people for?
I think probably the first advice, you're treating a patient or you're treating a person, not a patient. And so you're not treating a diagnosis and you are treating a patient. Treating that person as a real person. I keep on saying patient. Treating that person as a person is really important. A lot of times these people have been to multiple, specialists or multiple medical practitioners, and they're given a diagnosis and their story isn't being heard. They're being kind of dismissed. They're not being validated. And so, they come along and they just want someone to hear them and to listen to them and validate that they are in pain and that they're
that's
suffering.
so important, isn't it? Yeah.
So I listen a lot. I think that's really important. Let them tell their story and try to get more than just a diagnosis out of this person. What are the other factors that are going on and influencing their lives? And, where can you help out with that?
Yeah.
Then let's see. I think I talk a lot about pain, and there's sort of this ongoing debate about, they call it pain-splaining and explaining pain and how much of a role that has to play. And I think that that's a really, really difficult thing to do, is to explain pain to someone in a way that they hear that, their pain is real without hearing that it's just all in your head, which is oftentimes what they get told, and what they hear is, oh, you think there's nothing wrong with me physically, and so I'm making it up, or my pain is not real. It's not due to tissue trauma. And I think that's really, I actually find that really important, to be able to explain pain in a way that a patient can understand how pain science sort of works and not feel that it's all in their head. But it's a really complex, pain is actually a really complex thing. And so I spend a lot of time making sure that I try to explain it really well and clearly to them. And I think that's important.
So it has complex mechanisms, but you need to connect with a person and avoid, the first thing you said was listening to somebody. And a great way to appear that you're not listening is to talk about something that they feel is not relevant as well.
Yeah.
So could you explain pain to me? And I don't have any at the moment, touch wood, but let's say it's some chronic lower back pain. Sure. And I met you for the first time. You perhaps, what if we go back a step? If I had met you for the first time and I have persistent, we'll change. So the language is now persistent lower back pain rather than chronic pain.
That seems to be the trend in the literature now.
So I've got persistent pain for more than 3 months, as you said, in my lower back, and a variety of psychosocial yellow flags going on, and biochemical changes, and potentially some psychological changes as well. And what sort of assessments would you have done on day one?
Oftentimes on day one, I'll ask them what they know about their condition and what they believe, and trying to find out, what have they been told, or what have they, what do they believe, and are those beliefs accurate, or are they, inaccurate? Because essentially at the end of the day, pain is an assessment of threat. And if you don't know a whole lot about why you're feeling what you're feeling, well, that makes you more threatened because you don't know much. Fear of the unknown makes things worse.
Makes sense. Yeah.
And so if they've got some really unrealistic beliefs, or they've been told, things that are not helpful, which is probably the other thing that I would encourage people not to do, is catastrophize their pain and, tell people how bad they actually are.
So this is a clinician or practitioner talking to your patient to avoid adding to that catastrophizing.
Yeah. The number of times that patients will come in and say, I saw my doctor, my chiropractor, my GP, or my surgeon, and they said it's the worst back they've ever seen, or things like that. That's not helpful.
Do people really say that stuff?
They still do. And
sometimes I question whether these things are said or that's the interpretation. And I'm sort of always giving my colleagues the benefit of the doubt, but at the same time, if that does happen, let's call that out as well.
Yeah. And you're right. But it's, what did the patient hear? And what did they take away from that consult? And then how did that contribute to what they believe about their condition now? And so correcting that, or clarifying some of those unhelpful beliefs is probably one of the first things that I do. But you want to know what's important to them. What do they want to know? What do they need to know? Before you just go in and start telling them about, this is what is actually.
And that's back to your first point about listening and beliefs. So listening and teasing out their beliefs. And then you mentioned pain as a threat and the alarm system of the body, which is, do you still use that analogy of the alarm being stuck on? Is that a useful analogy for some people?
I think it probably is for some people. I don't use that one as much.
Yeah.
But I think that I can see how it's useful, but probably not one that I use as much. When I explain pain to people, I guess the main thing that I say to people is that our body never tells our brain to make something hurt. Our body just lets the brain know the situation that it's in, or the state of the tissue. It's up to the brain then to decide what to make with that information. And a lot of things go into that decision making. So I think of pain is the brain's answer to a question the body asks. The body says, "Hey, brain, there's some chemicals in the area. What do you want to do about it?" And the brain then has to answer that question. And to do so, it goes to a lot of different parts of the brain. It goes to the posterior parietal cortex, which is where your memories are kept, and it kind of looks for context there. Have you got any similar memories, been in similar situations, felt similar things, been doing similar activities? What was the outcome of that? And it adds that to the equation. It does go to the sensory cortex and says, what does it feel like? But then it goes to your dorsolateral prefrontal cortex, which is where your knowledge is kept. And it says, well, what else do you know about this? What have you been told by doctors or physios or chiros or your buddies at work? Or what have you read on Google? And that gets plugged into the equation. Whether it's accurate or not, it gets plugged in. But then interestingly, it goes to your amygdala, which is where your emotions are kept. And it kind of looks at, what is your emotional state like? So how stressed and depressed and anxious are you versus how protected and loved and safe and, comfortable are you? And all of that stuff gets plugged in. And then the brain decides, I'll make that hurt. Or it might decide, I'm not going to worry about it.
So that first rule of medicine of do no harm comes in there in terms of the knowledge.
Yeah.
And everyone acts with good intentions, but we could contribute to the condition by talking about, potentially even talking about biomechanical and structural loading related things.
Some people, that's what they need to hear. And I guess it goes back to listening and finding out what is important to this person that is sitting in front of you right now. What do they need to know? What is relevant to them? Some people need to know, how much can I use this? How much do I need to rest it? How much do I need to move it? How much do I need to protect it? Other people, that's not really important to them. They need to know, is this going to kill me? Or is this going to, make me have to get a different job? The big things. Other people, right. Other people are just like, I know I'm going to get over this. Tell me how to get over this. And that's where you got to listen and figure out what's important to this person to make them feel comfortable and not as threatened by their injury.
That's a powerful message. So then I'm still the patient and I'm still seeing you on this day one consult, and you've been listening to me, and we've been exploring previous knowledge, fears, my understanding, my goals.
Mm-hmm.
And so a lot of that will be happening without you saying, I'm just going to ask you about your goals. You're going to be actually listening to the person, and those things might come out spontaneously,
Mm-hmm.
or you might be questioning them, questioning me if I'm the patient or the person with back pain. Let's talk about some contributing factors then. So you mentioned a big one being depression, anxiety. We can screen for those.
Yeah.
We can refer people on when appropriate, and childhood trauma as well.
Yes.
Tell us about that one, because this one will come out in a minute when you talk about some of the early findings of your PhDs. It's really interesting and perhaps under-recognized under-recognized in the public, perhaps, but in the emerging area of research. So what's the connection between childhood trauma and persistent pain?
Well, it is emerging. It's not established yet, but we're starting to see more and more connections between bad childhoods and all kinds of chronic health issues, diabetes, obesity, depression, low socioeconomic status, difficulty maintaining jobs, poor social friendships, all those sort of things. And that we're starting to see association with chronic pain as well. I guess to go a little bit technical, so we have our nerves that go from our body, and then we have our nerves that go to the brain. And at the spinal cord, there's a junction where the nerve coming from the body meets the nerve that goes to the brain, and it sends a chemical signal across that synapse to the nerve that goes to the brain. And most of the time what happens is that nerve or that chemical just sits on the surface of the nerve. It doesn't actually enter that central nerve. And there is a chemical called GABA that prevents that from happening. And GABA is sort of like volume control on life. And I guess the analogy that I use is that if you go to a normal household where, mom and dad have a good relationship and they love their kids, and, they're doing their best to raise them and they genuinely have good intentions, and, I guess your normal sort of TV household or family. And anyway, dad's not much of a drinker, but one night dad goes out to the pub with his friends. He has a few drinks. He comes home. He's a little bit drunk, a little bit tipsy. A normal 8 or 9-year-old child isn't going to notice that dad's eyes are a bit glossy or his cheeks are red, or maybe he's slurring his speech a little bit, because that's GABA saying, don't worry, you're safe. GABA is sort of like the filter that says, all right, all of these things are trying to get our brain's attention, and GABA has to decide what gets through. And so GABA says, no, that stuff's not important. Don't worry about it. You go to a different household where dad's a drinker, and when dad drinks, he gets violent. Well, it pays for that child to pick up on some of those clues that, hang on, that's the look in dad's eye. That's the way that he comes in the house. That's the way that he, throws his briefcase down when he gets in and he's had a bad day. I'm in danger here. And that's because over the years, that 8-year-old kid has reduced their levels of GABA to allow those danger signals to get through faster. And they increase their cortisol levels, their fight or flight levels, their stress hormones, to try and protect them from that dangerous situation. And it turns out that GABA levels don't normalize just because the child's grown up and moved out of house, or maybe because dad actually did sober up. It turns out we stay with these low levels of GABA, these heightened levels of cortisol. And then the next threat that comes isn't, a drunk dad. It's a bulging disc or a broken leg or something like that. GABA's not there to sort of say, let's just turn down the volume of that pain. And so those chemicals go to the brain much, much faster and stronger.
So it can really generalize and be persistent across the lifetime. It's in terms of that physiology. Okay.
It seems to be, yeah.
Yeah. So let's get a take-home message for clinicians and students who are thinking about broadening their idea beyond biomechanics and beyond patho-anatomical tissue model, and thinking in biopsychosocial model and thinking about pain, and how can we assess? Obviously, part of your PhD is actually directly assessing some of these neural connections. Yep. We could talk about that in a minute, which is really interesting. And it's really important to do basic science research and then connect that basic science research to clinical patterns, which is what you're doing, which is really interesting. That knowledge of GABA being that volume control, and that knowledge of that can stay with someone for their lifetime. How can we apply that? How can we apply that knowledge clinically?
Well, it's funny. Like I think, first of all, you ask about it. I ask all of my patients that seem to have persistent pain about their childhood, and not all, but I would say 60 to 70% of them, they go, oh, where do I start? Or
so is that just an open question where you're just interested initially?
How do you get along with mum and dad?
Yeah. And there are questionnaires, and of course there's referrals to specialists and psychologists and people, but in a standard physio consult, an open question. Yeah.
And I start with that. If it seems like they've got those chronic pain tendencies, then I will ask about their childhood. And it's probably not something that we as physios are certainly not trained as part of our regular training to deal with, but it's something that you identify and you go, okay, well, that's a factor and we might need to deal with that. Yeah.
Yeah, that's really interesting. So the knowledge so this is where mechanisms can be really complex, and then the pushback on always thinking about mechanistically and the complexity of things, and particularly arguing online about mechanisms. And I spoke to Greg Lehman last week about this, is that does it change what you're going to do? To me, in this case, the knowledge of that physiology and the knowledge that childhood trauma can directly impact what's going on now is a mechanism we should be aware of. That's something we should be thinking about.
Yeah.
So it might, that's maybe where it starts, is with knowledge that this can go on and some questioning, and then what you do about it can lead on from there.
Yeah. And I think just being aware of that as a background, it sort of changes your expectations a little bit. And it might change, maybe not my management, but it might help change who you bring into the team that is going to help this person. Sometimes it's not a factor, and, there's other things, but when it's there, it's something that I usually go into a little bit more about, how have they dealt with that now as an adult, and does it still bother them? And I think, because I do this a lot, I'm better qualified to help treat these patients. I think your new grads and your younger physios, and even just your physios that don't generally deal with chronic pain, it might not be left to them. It might be something where you refer them on to psychology and that sort of thing. But it's certainly good to be aware of that as a potentially contributing factor, and potentially quite a significant contributing factor to the condition that they're in right now.
In our health system, we're primary contact practitioners. So people will come in off the street and often not knowing what's wrong with them and not knowing any of this. And so it's great that we have experts working like yourself that you can refer. I could refer myself or refer somebody to you today, and you would write a letter back, and we could send you that business, I almost said, but send you that person there for help. But you still have to do something as a new grad. So let's talk about some of the things you can do if you've been out for a month and you see someone with obvious complexity in their presentation, and you can always help someone. What can you do?
Absolutely. I think it's important that the new grad recognizes that the person with chronic pain, their brain perceives their body differently than before that injury, or the way that, I guess, healthy people perceive their body. Their homunculus, you new grads would probably know the human homunculus, that changes its representation of the body. And we can assess that directly in the clinic. And so one thing that you can get them to do is ask them to just close their eyes and visualize what they think that body part looks like. And often if they've got, if it's low back, it might be different, but if it's a foot or a hand, compare it to their uninjured side in their mind's eye. If the patient has a different mental image of that body part, you can get them to actually visually correct that image. So they consciously change that image so that it looks more normal or more accurate representation of what it really looks like. That's something that most patients, it's a really good tool because they can see it in their own mind. They go, it doesn't look right. And they can kind of tell that, okay, there is something that is different about the way my brain perceives my body. I do a lot of tactile type stuff. So 2-point tactile acuity. Can you feel 1 or 2 points of contact? So you can get little calipers and you can say, is there 1 or 2? Compare that to the other side or to different body parts. And it really challenges their brain. You can do, is it sharp or is it blunt? Those sort of tactile things are really good because it's stimulating the body part that they've been really, really protective of, but it's giving it some stimulation, some afferent stimulation or afferent input to the brain. But it's also making them look at that body part as more of a problem to solve rather than something to fear. So is it 2 points of contact or 1? I don't care if it hurts or not. I just want to know, is it 1 or 2 points of contact? And so they're thinking more logically about that body part. I do pressure testing. So, I've got a little pressure gauge device that I can push onto their body part. And I'll say, tell me when you get to a 3 out of a 10, and I'll push it down. Oftentimes, the patient with chronic pain, or persistent pain, they'll have a pain threshold of a kilo of force, and that's it. You go to a different body part, tell me when you get to a 3 out of a 10, and it'll be up to 10, 15 kilos of force. And then
wow. So in the clinic, you really see a huge difference between the skin over the affected or near the affected area and an unrelated area in that pressure pain threshold. Wow. Yeah.
And I find that then I'll go and, okay, I'm going to show you what you got in your pain area. I'll show you, let's say they had a 1 kilo of force over their low back, which is where their pain is. Then I'll go to their hand where they don't have persistent pain. And I'm going to show you what you felt in your back and when it became painful, and you do that 1 kilo and they go, no, you're kidding. And again, it helps them to realize that the way that they're perceiving their body maybe isn't as accurate as it.
So you're working with them, you're understanding them, you're listening to them, you're still ticking those important parts off, but this is assessment and management as well.
Yeah.
What other management do you use? I'm thinking exercise.
Yeah.
In a way, this is all in the education sphere, isn't it?
One of the things that patients with persistent pain have is we see big changes in the way that their muscles contract, their motor units. And so you kind of think about your muscles like hands that pull on a rope. You've got, let's say in your grip, if you want to squeeze your fist, you might have 20,000 hands that can pull on 20,000 ropes to squeeze your fist. If I got to lift up my coffee cup here, my brain knows that that's a very light object. I don't need all 20,000 hands to pull on that to engage, because that coffee cup's fairly light. People with persistent pain, they work a lot harder just using their muscles. And so they will use, instead of maybe 3,000 hands or motor units to lift up the coffee cup, they'll use 80% of their motor units. They'll use 8,000 to try and lift up that coffee cup. So they're exerting a lot of energy to do that. So we use just simple things like biofeedback devices and teach them to learn to modulate how much they contract their muscles.
Interesting.
And that can be quite helpful, because they learn to sometimes it's not about being stronger, it's actually about using less motor units for your lighter tasks, so that you've got more reserve, you don't fatigue as easily. One thing that people with chronic pain have, they go, I can't do anything for too long. And part of the reason for that is because they're doing everything they do, they're doing at near max capacity. You're going to burn through their energy supplies early, much faster. They need to go home and rest. Teaching them to modulate their muscles is important. It's just as important as increasing their strength, which they're also usually quite weak.
So exercises in many ways can be quite simple.
Yes.
But the thinking and clinical reasoning and the science behind them can be really complicated as well.
Yeah.
Now, obviously here we're trying to keep things simple, digestible, foundational, and someone, you're not going to take out the FNIRS or the TMS machine, which is something that you do in your PhD, and directly measure the function of the brain, right? But knowing that knowledge isn't superfluous just because you can't measure it in the clinic, right?
Yeah.
Understanding these mechanisms, that there are some simple assessments, and also it was interesting how you use those as teaching tools. For example, the pressure or the biofeedback on those overactive muscles. What's the role of general exercise for pain? This is a potentially controversial topic. Is it specific exercises or getting people generally active?
Generally, the evidence seems to be that just exercising is what we should be doing. These ideas,
so going for a walk, going for a run, doing something that's pushing you.
Yeah. What we really want to do is most of these patients, they have withdrawn so much from their lives in trying to avoid pain. That becomes their main goal, is to try not to do things that make things hurt, so they don't do things. Trying to get patients to feel safe enough to actually just move and try to lift things up. That's kind of the main goal. And so finding something that they feel, it needs to be something that is uncomfortable for them. It's got to be a challenge, but a challenge that they can do. We want them to have success.
Yeah.
I suppose I have a bit of a rule. If I have a patient that has, persistent pain, they're always in some degree of pain. Hopefully, we can get them so that they're around a 3 or 4 out of a 10, at their general comfort levels. That people often have we use this, this scale of 0 is no pain, 10 is the worst pain ever. And where are you on that scale? People with persistent pain almost always are up at the high ends of that scale. They'll be at 7, 8, 9, just sitting there in the chair talking to you. And that's probably not because they're actually in like an 8 or a 9 out of a 10. It's because they no longer have a scale. They have a dichotomy. I have 0 pain, which is what I want, or I have some pain, which is what I don't want. And so that pain is going to be very intense. And they don't know what 0 out of 10 or like a 3 out of a 10 is anymore.
Right.
So we need to reset that. Once you sort of reset that, we get them to a baseline and we say, okay, you're at a 3 out of a 10. We're going to do an activity until you go up to a 5 out of a 10. And then we're going to stop that activity. Now that might be a 10-minute sort of workout. It might be a 45-second exercise or something like that. And then we will stop that activity until they've returned to their baseline. And those sort of general guidelines can be good for both the clinician and the patient to sort of abide by, because it gives them a bit of structure and things to work towards.
Have those same general guidelines with other conditions as well. Like Greg was talking about last week, when you zoom out and take a wider view of the principles that we work with in rehab, often you see similarities across different conditions and you think, hang on, this is similar stuff. I was thinking of tendinopathy there with immediate and 24-hour responses, but the importance of the person being aware of that and not just you instructing them, but I'm going to go away for a week now and do exercise, and I've got a plan. I've got a bit of a roadmap for what do I do. When it gets worse, and thinking about the response, the latent response.
But if the patient goes and they do an exercise and they get a little bit of increase in pain, they're always in pain anyway, so they get a little bit of an increase in pain. But then that pain kind of goes back to what it was before they did the exercise. Hopefully they can kind of see, hang on, I had some success with whatever it is that I just did, and my body's not worse from it. Maybe I can do that again. And, that expands their envelope of function a little bit. That gives them a little bit more functional capacity, a little bit more that they can do.
Yeah, great. So PhD, how's it going? I know you very well, and I'm working with you on your PhD. Tell everyone about your PhD and what are you trying to measure and do, and what's it all about?
Sure. So PhD is about people with chronic low back pain and trying to understand a little bit about what is different between their brains and their neurochemistry and their brain activity compared to people who don't have persistent pain. Started out just looking at neurochemistry using TMS, transcranial magnetic stimulation, which gives us an indirect idea about a few neurotransmitters, in particular GABA, which is again like an inhibitory, calm shit down neurotransmitter, and their glutamate, which is a kind of fight or flight.
Another Greg Lehman reference there.
Yes,
from last week.
Yep. Calm shit down, build shit up. So it looks at the neurochemistry, and if they have reduced levels of GABA or reduced levels of glutamate, we can kind of get a pretty good indication of that. We just finished that big study. It took about 2.5 years because we were locked out for about 2 of them with COVID. So it's a bit frustrating, and found really cool results. So we found that we looked at actually not looking at the low back. The way TMS works is you put some electrodes over a muscle, and then you put a magnet over the brain, and that magnet tells the brain to tell that muscle to contract. And then based on the size of those contractions, we can get an idea about their neurochemistry. We actually didn't use the low back, mostly because it's really painful to do TMS on the low back. And so we thought, well, we're probably not going to get enough subjects that'll undergo a painful.
So just to update the listeners, I've been a control subject in your study. And so you sit in this chair and you have a coil that's placed over your skull. The magnetic stimulation goes through the skull and it's painless. It just feels like someone's tapping on your top of your head like they're playing the piano on your head. And repeat that many, many times. And you get lots of different data points from the person. And then you're measuring the contraction of the associated muscles, so stimulating the motor cortex. And most of that crosses over the pyramids of the medulla, doesn't it? Goes down the other side and stimulates, say, the quadriceps on the other side. Yeah. And sometimes you get a spot that does nothing, and other times you'll stimulate a little spot on the cortex where your leg goes doing, and you get a involuntary contraction, and that feels weird.
Yeah,
but it was pain free. But what you're saying is, if you did that over the part of the homunculus on the cortex, associated with the lower back and then put the electrodes over the lower back, that would be really uncomfortable. It feels like a spasm in your lower back.
Yeah, there's a couple of reasons.
Can I avoid that when you do that? I'll be sick that day.
Yeah. The part of the homunculus that controls the back is kind of buried deep in the brain. So you got to use a big magnet, a big coil.
Right.
And you got to put it on a fairly high intensity. And so there have been studies that have done it in the past. And one of the things is there was a high dropout rate because the subjects didn't like it. So typically most TMS is done over the thumb. So the thumb, our brain devotes tons of brain space to our thumb because it's what makes us human. And so it's very easy to get a contraction, a stimulus over the thumb. But the thumb in the brain is actually really close to the face. And we found a few of the patients with pain didn't like the face twitch that came with it, myself included. I really hate it when I do TMS on the thumb on myself because it just is uncomfortable. And so we thought, well, let's go down to the tibialis anterior, down to the shin. And it's a lot more comfortable. You can still get a twitch out of it. And the thing that I like is most of the kind of the pain science theory has always focused on, with the TMS and the neurochemistry studies, it's focused on the part of the body that is in pain. So if we're looking at low back, it'd be muscles around the low back. If we're looking at, the foot, we'd look at muscles around the foot. But to me, it seems kind of unrealistic to think that the changes that happen in the brain and the neurochemistry of the brain are somehow only isolated to just the body part that's in pain. I think that if we kind of consider that this person has high stress and high anxiety or depression or childhood trauma or, whatever it might be, that's probably not just going to be happening. Those neurochemical changes are not just going to be happening in the homuncular area that has their back. It's probably going to be throughout the whole brain. And that's what we found. We did find that people with chronic low back pain had lower levels of GABA or lower levels of inhibition. They were more facilitated than healthy controls in the area of their body part that is not in pain. So we didn't have anyone that had sciatica. We didn't have anyone that had leg pain or paresthesia or anything. They just had low back pain, non-radicular. So they had altered neurochemistry. So that was really cool. And then we also were able to link that to childhood trauma. So there's a test called the Adverse Childhood Event Score. And it's a series of 12 questions that asks if they had physical, sexual, mental abuse, neglect, drug and alcohol use, someone in jail, mental health issues, suicide, violence in the family, those sort of things. And what we found is none of our controls. So we had 25, 26 controls. None of them had high levels of trauma. Most of them, if they had any, they had divorce. And that was it. None of our controls had high levels of childhood trauma. And not all of our chronic pain patients had childhood trauma, but a vast majority of them did. Somewhere around 75 to 80% had high levels of childhood trauma. And there was a direct correlation between the more yeses that they had on that scale, the more different their neurochemistry was. So it does seem like childhood trauma might be causative of changes in neurochemistry, which might then be associated with chronic pain. So I think it's a very cool study.
Novel and really important. And of course, then it takes, the next step is then to explore prospectively, so across time, and then develop interventions and different approaches for people in the clinic. But I guess if I'm a clinician listening to this, and I hadn't considered the real impact, or wasn't quite sure whether it was real or not. So you've got some evidence here that there's potentially a causal link.
Yeah, and fairly strong. Pretty good evidence. The numbers are good.
So there's just so much you can go into on any topic. Right? Yeah. We could record 10 podcast episodes right now on this topic.
They always say it's a danger to give any PhD student a platform to talk about
that's
their
right.
PhD. Never ask a PhD student about their PhD.
Well, we should though. It's good because that's what you should be doing. You should be talking about it and publishing your research and everything, but often they're behind a paywall. They're presented at conferences. Not everyone can go. That's important, the traditional academic model, but podcast, the whole point is to talk in a free, natural, unedited way and make real connections. And you started this conversation with some vulnerabilities and admitting, you were frustrated by trying to help people.
And still am sometimes. They're still difficult. They're the most difficult people to treat, I think, are the ones with chronic pain and complex lives.
And there'll be listeners out here who aren't at your high level of experience who feel the same way. And you don't get that from reading Mac's article that's published in the journal. That's important as well. But talking about this stuff really matters. And in I call it a fireside conversation, sort of a relaxed way, really exploring it together. So any final thoughts that you want to share with our audience on managing pain in the clinic?
I think there's a few things. One, I think it's really important that you develop a good rapport with your patient or with the person that you're treating, because they need to trust you. That most of the time these people have been let down by both the medical system and just people in their lives. They have, it's very rare that I get someone with persistent pain that has everything else going for them in their life. They got good jobs and they're happy and their marriages are great and they've got good kids and they're financially well off and they're just happy people, and they have chronic pain. I just don't get that patient very often. So you are dealing with people that have been let down. They're the vulnerable people in our society.
Potentially trust issues, resentment.
And so they need to trust you. And so listening to them is really important, and validating what they're feeling and what they're experiencing is really important. And then there is no recipe. There is no, here's how we treat this and here's how we do this. It's a lot of trial and error. And, what we kind of do with pain patients is we take everything we know about pain science and we throw it at the patient and see what sticks. And it's frustrating, but sometimes I do like the graded motor imagery where they imagine their body limb and it looks pretty much like it should in them. Oh, that's not what I expected. You do, strength stuff and they're really, really strong. That's not what you expect. Sometimes, you just don't get what you expect. And so you go with what works for the patient.
So I see the problem with my earlier question, which was me being a patient with lower back pain, chronic lower back pain, persistent lower back pain. So you really, there's no one approach that fits everyone, which wouldn't surprise anyone listening to this, but especially with people with persistent pain.
It's just, it is trying to find what works for the patient or for the person that's in front of you. Some people, it is a lot of tactile acuity stuff and getting that afferent stimulation. Some people, it's more exercise based. Some people, it is more mindfulness and meditation. And, I use a lot of imagery or even like aromatherapy and that sort of stuff and trying to divert their brain from dwelling in that pain.
Right.
I think probably my favorite analogy is and it's a visual image, so I'll want to edit it out, you can, but I think if you kind of think of pain as, say, you draw a circle the size of a golf ball.
Right.
All right. And you say that's pain. And then you draw a slightly larger circle around that golf ball, and that's that person's life.
Right.
Pain is a large part of their life. The goal for most people when they think about it is they go, let's make that golf ball smaller. Let's make the pain smaller. But a lot of times that doesn't work. Either it's not possible or it just doesn't work. So if you draw that second golf ball, you draw another circle, the same size as that golf ball, call it pain, but draw something that's much, much bigger, like a basketball around that and make that their life. That seems to be a better approach in my experience. Make life bigger rather than make pain smaller.
Wow. That's a really nice way to look at it. So
can't claim that as mine. I can't remember where I've seen it, but it's not my own analogy. Someone else much smarter than me came up with that. I just like it.
No, that's really good. So I think we've really just touched the surface there on a number of important components, but we've been able to delve into a bit of your thinking as someone who's an expert in this area. So I'm really grateful for your time, Mac. Thanks for coming on for the first in-person Physio Foundations interview. Susanna and I have sat there with these mics talking to someone on Zoom, but it's good to do it face-to-face and enjoy a coffee. So really appreciate your time. Thanks for coming on.
Really appreciate you having me. It was really, really fun.
We'll have to do it again. There's so much more we can dive into, but we'll leave it there for now. So thanks everyone for joining us, making it this far into the conversation. So don't forget to share the episode. You can connect with us on social media at Periton Physio. That's Susanna and I, or me at Luke Periton. Mac, you're on Twitter.
Yes.
What's yours? What's your handle?
I actually don't know.
I'll put it in the show notes. He's on Twitter. I'll put it in the show notes so you can look him up there, and you can follow Mac's work. in journals, but your research profile as well, I'll put that in the show notes as well.
All right.
So you can look up Mac and find out more about him and his work. But for now, thanks very much, Mac.
Thank you. It's great.
So until next time, this is Mac and Luke wishing you all the very best with your studying, professional development, and lifelong learning.